It's a great pleasure to be with you all today. I'm an obstetrician and gynecologist, but I've taken on the challenge of summarizing what is happening with the COVID. So I like to compare the future of humanity after COVID-19 based on the Spanish flu experience. Well, every 100 years, there seems to be a pandemic coming on to us. And 1720, it was plague, 1820, it was cholera, 1920, it's Spanish flu, and 2020 is coronavirus. Now, usually, the deadly influenza pandemic caused by H1N1 influenza A virus, that was the Spanish flu. And it started in February 1918 and finished somewhere close to April 1920. It infected more than 500 million people, a third of the global population in 4 successive waves, and estimated about 17 to 50 million people died. So it's one of the deadliest pandemics in human history. So that was H1N1 influenza. Even it is present now, but in a milder form as a sporadic incident. Now, although it's called Spanish flu, it is because Spanish news media and the papers reported it, because that was the only country that was not involved in the 1980 World War. But it started in Kansas by the US Army who were traveling to Europe. So it spread through the armed forces. The only country which was spared of this infection was Australia, because those days the travel was mainly by ships and they banned any ships coming to Australia. So they were free of it, whereas all the other countries virtually got infected. So that's the background we had to take. What is the lesson we can learn from the Spanish flu and how this has been evolved? Well, I think I'm going to touch as objectives the precautions we can take, what are the prevention, treatment, vaccination, and can we achieve herd immunity? Like Spanish flu brought it about by natural infection, but can we achieve it by vaccination? Now, this is one of the first notices to appear in 1980 from a place called Kelowna, which is actually in British Columbia. And the public notice says, notice is hereby given that in order to prevent the spread of Spanish influenza, all schools, public and private, churches, theaters, movie picture halls, pool rooms, and other places of amusement, lodge meetings are to be closed until further notice. And all public gatherings consist of 10 or more to be prohibited. So the same lesson we have applied to the current epidemic or pandemic to reduce the chance of transfer. Now, at that time, they thought it was by saliva. So they said the Spanish influenza has ended, and in the Navy Yard, 30 deaths have already resulted. Spitting spread Spanish influenza, and don't spit. So similar to what we are trying to do now. And then wearing the mask came, and they were wearing slogans like wear a mask or go to jail. They took it so seriously because they know things are getting from bad to worse. And the children were asked to wear some camphor satchels around their neck because they thought that'll ward off the H1N1, but it didn't spare anyone, it infected. And the older generation were given the army warm saline gargle to avoid infection. And if you go into the internet, even now about the COVID, there are so many medications and so many self-remedies prescribed, and nothing is going to work. The personal protective equipment became a major important thing, especially in transferring patients. And you can see, even at 1918, everybody was wearing the mask and be careful about how to handle. And there was a mass production of PPE because you can't turn it on. If they use it once, you have to. So one of the problems which encountered with the COVID pandemic as well was not enough personal protective equipment in many countries. And this is quite important. Now, unlike now, there was no major intensive care facilities with intubation, ventilation, and other things. So it was in an open ward, and patient came in the morning, vomited blood, coughed, difficulty in breathing, and they died the same day or the next day. So the turnover was very high, and that is what is happening in some of the South American and the Italian countries. Now it seems to be in the UK as well. A lot of admissions, and some patients are ventilated for 28 days more, and they die. So it's one of the problems when they get into the hospital. Now, compared to the 1918, we are better off now because of the availability of enough oxygen, ventilators, highly trained staff who can give anticoagulants, look after other organs which go into failure. Now, one thing we must remember at the outset, unlike the H1N1 influenza, which was a respiratory tract one, the COVID or coronavirus affects all the organs, the kidneys, the brain, the heart, and so forth. Now, this is how it came to an end in terms of Spanish. There were different spikes, as you could see all along the way. There were major 4 spikes, but influenza lingers as endemic flu with minor mutations after being conquered by herd immunity after infecting 500 million and losing 50 million lives. So if you're going to let the COVID run its own course without immunization, this is what is likely to happen. We are going to have more than 500 million infected and 50 million lives will be lost. So what we are trying to do nowadays is to give good treatment, good care, to reduce the losses, but also bring in vaccination so we can stop the lives, at least 2 to 3 million, and save 47 million lives. So can we achieve it? And can we reduce the infection from 500 million to 200 or 300 million? This is the question we have to answer. So can we do better with COVID-19 in 2020 compared to Spanish flu? That is the statistics I gave you just now, 20 to 50 million deaths, 500 million infected in 4 peaks. Well, we think we can do better because there is better testing, there is availability of antivirals, steroids, and now anti-rheumatoid arthritis drugs are being used. Track and trace facilities are available, better ICU facilities, and effective vaccines are rolled out now to bring about herd immunity. So we'll go through each one of these one by one. Testing is for the antigen or the virus, and for the defense, for the antibody. We must know when to do the antigen and when to do the antibody. Antigen for those who are ill, those who came in contact with the ill or pre-symptomatic carriers. One of the major problems with the COVID is there is asymptomatic carriers and pre-symptomatic carriers. The asymptomatic, they won't know they got COVID, but they got minor infection and they passed off. Pre-symptomatic are those who didn't know they were getting infected, then they got infected and got the symptoms. So that lasts up to 14 days. And that is one of the reasons you have to wear the mask and so on. So if you are in the pre-symptomatic or asymptomatic phase, then you don't pass it on to the other people. And, you know, if you're going to Japan, there are a lot of people who are wearing masks, not because they are paranoid, even those days, but if they have a cold or illness, flu-like illness, they wear the mask in order to be courteous and to protect the others. So to calculate, another reason to know the antigen, whether it is present or not, is to calculate the prevalence or R rate. That means one person infected can pass it on to how many people. So today there are only 100 people infected. Tomorrow 300, that means each 100 of them passed on to 2 people. But if 100 today are passed on to 500 people, but tomorrow are testing, then they are passed, each one has passed to 5 people. So that's the rough way of calculating the R reproduction rate. Now, the most important people who have to be tested for antigen or virus is the healthcare personnel, because they will go and infect the others, care workers in the nursing care, food and hotel industry, transport industry, and those who come close to people. This is to avoid transmission, but it is not one-time testing. It has to be repeated testing. It can be once a week or twice a week or every 2 days. And also travelers, if you're going to travel, you don't want to pass the infection. So it might be better that you test, and if you're positive, you don't get into the plane and pass it to the others. Now, as opposed to the antigen, antibody testing is to find out who was infected and whether they may be immune and confidently return to work, like an immunity passport. So in other words, if they had infection mild, which they didn't recognize, but they have developed antibodies, they might be relatively safe. Reinfection is possible, but they might be relatively safe. So, and secondly, to decide on who needs vaccination, because if it is within the first 60 to 90 days of an infection, then it may not be worth vaccinating. But it is advisable to take the vaccine after that period, because they can improve the T cell immunity and the possibility of more resistance, and thereby can bring about herd immunity by vaccination. Now we have to remember that the B cells are the ones, the plasma cells, which produces the antibody, which has a boost in about 21 days to bring about a lot of antibodies, different types of antibodies against the virus. But then there is a cell immunity by the T cells. And for the T cell immunity to really be kick off, you must have initial vaccination followed by a booster vaccination. The second aspect is, where do we take the swabs? Because if you see the television news presentation, they have to open their mouth and the nose, and the patients feel comfortable. They can even splash on you and make it worse. And this is a study published in the New England Journal showing collection from the tongue swab, nasal swab, and mid-turbinate swab, as opposed to the nasopharyngeal swab, about 500 cases in each. And as you could see, there's a very close correlation, because when the virus gets infected and it's in the mucous membrane of the pharynx and the larynx, it doesn't spare the tongue or the things, and the secretions will have it. So there's no point trying to do a more cumbersome procedure where you can get it easily. And this allows home testing and hospital testing and so on by the individuals themselves. And recently there has been a meta-analysis which also proves the same thing, that salivary testing is adequate. Now, what about this antibody testing? As you could see in the box, antibody testing is not good enough in once if you test it, but you have to do repeated testing. Let's say surveillance should be maintained to find out how long does the antibody last, because that is quite important for us to know. So need for longitudinal serological study for duration of immunity. The main role of testing then is to identify current or previous infection. They may not have had symptoms, or the antigen test may have been negative if they took it at the wrong time. But if antibodies are present, then we can assume there's a low risk of getting infected and passing it to others. Total number of people already infected and developed antibodies can be calculated. So you can see whether we can build up herd immunity. If the total population tested for antibodies, only 5% has antibodies, then that's not good enough. But if 80% have antibodies, that's good enough. So it'll help to formulate a strategy to manage the pandemic. Vaccination and serology testing for antibodies are quite important. And antibodies does not guarantee prevention of infection or transmissibility, but it is somewhat reassuring that chances will be less. So what are the testing times? Well, if you want to check the IgM antibodies, it comes up first, the large antibodies in 5 to 10 days, but IgG of different types to different parts of the virus comes in 21 to 28 days. So early testing, if you had done it before 27 days, it might be negative. And in an asymptomatic person with a negative result, they can spread infection because they thought they had infection, but if they go and get a test, I had my infection last week, then the test will become negative. Then they might walk around, but they might be still infected. So the second issue with checking antibodies are not all tests give correct results, because even if 90% or 95%, 5 to 10 per 100 are not giving the correct results, and they would be missed, and it could be due to a sampling error, a testing error, or an interpretation error. So you can reduce the error by testing twice or by using different methods to cross-calibrate, but this is not done because of the cost of reagents and the tests. And how long will the antibodies last, and will they be protective? Nobody knows. There's still data is being collected, but we do not know how long it will last. And whether it will be detected in 12 months. If you go by the experience of SARS-CoV and MERS, Middle Eastern Respiratory Syncytial COVID virus infection, the antibodies lasted years. So COVID-19 may display short period of antibodies depending on the severity of the disease. Whether and how much it will be protective is not known. So we have to really follow these cases up to see how we are. And what about the issue of readmission due to COVID? This is a paper which came out recently. Nearly 1 in 10 patients who are discharged after receiving inpatient care for COVID earlier this year was readmitted within 2 months. So 1 in 10, so it's a big number. To help fill the knowledge, CDC investigators analyzed the records of 126,137 patients. And those who admitted between March and July of 2020, they found that 15% of the patients died during their initial hospitalization. Among the survivors, 9% were readmitted, so 1 in 10, in the same hospital within 2 months. And 1.6 were readmitted more than once. So you can see it is not an acute disease which passes off, but it might come back again. And 15% of patients discharged to nursing home have readmitted to a hospital. So they were not completely cured, so they were readmitted. More cases were readmitted. And so the reason for readmission, of course, there were fewer than 0.1% readmitted patients died, so they probably had some immunity to withstand the reinfection, so very little died. But the diseases with which they were readmitted were circulatory, respiratory, digestive system were readmitted. Most common discharge of diagnosis were these three. So in other words, COVID is not only affecting the lungs, but also the cardiovascular system, the digestive system, and so on. Now, in terms of testing, there are test kits available, and this is an advertisement from Siemens, which says the company has a total of 20,000 systems to ramp up antibody testing, up to 50 million per month. So these are tests which might be used in many countries, but they don't have the facilities or the finances to do that. But wherever it is available, then they will do that. So antibody testing will be helpful in trying to find out how much immunity the individual has. And there are small test kits which depends on monoclonal antibodies, which are cheaper and can be done in 20 minutes. The accuracy is not the same as the PCR testing, but it'll be able to identify those who are at risk. So there have been a lot of papers published in the BMJ, New England Journal, JAMA, and so forth, how to best use COVID-19 antibody testing, and also later on. So you can see the second journal, which is shown on your right, antibody testing, new evidence questions accuracy. So there's always worry that how accurate the tests are and should we depend on this. So more and more people are trying to get onto accurate ways of determining antibodies. Now let us go to about treatment and how the virus operates. So this is the SARS virus on the surface of the epithelium, and it tries to angiotensin converting enzyme receptors there. It attaches to that and gets into the cell. And the problem is if there is no inhibition, it desensitizes that area. And if it is converted to angiotensin 2, then it is like a dynamite, as you could see on the surface. It releases a lot of inflammatory product, and there is an acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability, and so on. So we had to prevent, and that is one of the mechanisms, as you could see, if you're treating hypertension, you use ACE inhibitors or angiotensin receptor blockers. So you prevent that bursting phenomenon or rapid phenomenon. And based on this might be some of the anti-rheumatoid drugs as well. Now, there's a big question about these ACE receptors, and ACE receptors are found to be less in children compared to the adults, and that is one of the reasons why people push the children are not affected that much. And the horizontal axis gives the age 10, under 10, 10 to 17, 18 to 24, and over 25. And the vertical axis is receptor concentration. As you could see, with age, it goes up and up. Not that ACE2 receptors are less in children, but it's found in other sites. So children are a little bit immune compared to, because they don't have the virus to attach to the mucous membranes. And so based on these things, we can really calculate as to, is it safe for me to go to work? Is it safe for me to go to school? So school seems to be always a moot point, and children are also getting infected. So we have to watch that very carefully and study it a little bit more. But in terms of the adults, we can come to a logarithm, and we can see the horizontal axis risk of death from SARS-CoV-2, and vertical axis is occupational risk of contracting. So if you take the red, which is C, that means they are older age or middle age with high risk condition. and they are come in contact with people known to have coronavirus. So that is the most dangerous category, and that is the people who are living in care home, the elderly people who have comorbidities like diabetes, hypertension, Alzheimer's, and so on. And if they come in contact with contacts of carers who have coronavirus, then they are at the highest risk. Medium risk are middle age or young age group with high risk conditions, or those who are come in contact with unknown coronavirus status, but they are of old age group. So that red and yellow boxes are the people who have to be careful. The red box, of course, and the instructions as given below A, B, C. A is instruct the patient to wear a mask outside the home, practice recommended hand hygiene, and use PPE as directed. That is the green variety. Whereas the top risk is C. You have to counsel the patient on high risk of continuing to work and to consider stopping work. Counsel patient to take all precautions outlined in A. So you can really try to, that is how the UK government is trying to do who is at high risk and care homes and who are likely to come into contact and so forth, and ask them to stay locked in. Now, there is always a debate by the WHO, but although we say antibody testing might be useful, whether it is a certification for safety, how certain are we that the people will be protected? And also, we don't know about the transmissibility, about, say, if I have antibodies positive, I might be protected to some degree, but I might get some infection in my nose and pass it. And that seems to be the case based on observation and also on some chimpanzee experiments I'll show you later on. So I think it is best till the pandemic vanishes, like in the Spanish flu pandemic, till we cross over the bridge, we have to wear masks, wear personal protection, keep the distance, and try and avoid getting the infection. In terms of therapy, there is quite a lot described. Oxygen, which is a paramount, anticoagulation, because this disease gives rise to thrombosis. Kidneys might get affected. They might need dialysis. They might need plasmapheresis, dexamethasone, obviously. I'll talk a little bit about hydroxychloroquine and azithromycin, because that has come in quite a lot, and antiviral like ribavirin and remdesivir. BCG vaccination is thought to protect, and in countries like Asia, for example, they say there's less COVID. Might be that BCG has given protection, although there was a study from Israel which said it looked at a cohort of 5,000 who had vaccination BCG and not, and there was no difference in COVID infection. So there's question mark. Convalescent serum and monoclonal antibodies might be of help, and viral antigen vaccine, and vaccine for coronal pigs. There are different types of vaccine. So I'm going to enlarge this diagram how the therapy is looked at. And as you could see, the COVID virus attaching to the ACE receptors, and it fuses with the membrane and goes in. And this is the prevention at this stage can be by chloroquine and hydroxychloroquine. It inhibits viral entry and endocytosis by multiple mechanisms, as well as host immunomodulatory effects. Although the mechanism is there, it has not worked out so well. Now, the COVID is an RNA virus, and it is going into the cell, and the RNA gets out into the cytoplasm, and it makes its way to form more particles. So there can be RNA virus, the drugs against RNA virus, that comes as ribavirin, remdesivir, and Felisprevir. So it's quite a mouthful to spell all that. And that can inhibit the RNA replication. And I'll talk a little bit about ribavirin as possible therapy and what is that. And at the top of the picture, you can see the inflammatory products floating around, and these inflammatory products and immune response can be damped down by corticosteroids and anti-rheumatoid drugs. And what about giving oxygen? Can we give it just by mask or tube rather than intubation and ventilation? Is it better? But there have been a number of articles, and this is one from University College London, which says we can stick to WHO guidelines for the management of respiratory failure. That is CPAP or non-invasive ventilation, provided the appropriate PPE is worn. So there is no problem if you give PPE, good PPE and give CPAP and non-invasive ventilation. So it is not necessary to give invasive ventilation. One of the good things to suggest to patients, and studies from Japan has now revealed that people get fever and cough and they think it's a normal flu and lie, and people are found dead in Tokyo and other places because they didn't know how serious and how quickly the disease process is escalating. So if you want to give one small piece of advice is to get your friends and relatives to buy a small oxygen saturation meter from Argos or someplace, which is 15, 20 pounds, because if the oxygen saturation falls below 95%, probably they need admission with other symptoms. Venous thrombosis is another critical issue, and mortality of patients with COVID-19 admitted to ICU has been reported as high as 50%, and that is in cases where there is venous thrombosis. Venous and arterial thrombotic events have been reported. So one of the ways is to give some thrombolytic drugs or anticoagulant therapy, but despite anticoagulant prophylaxis, 15% of patients develop DVT only in 2 days after ICU admission. So it is quite a deadly disease affecting the vessel wall, and systematic anticoagulant therapy for all ICU patients should be assessed, but nevertheless, it seems to be one of the predominant issues in COVID. Now we look at remdesivir for patients with severe COVID-19, because that is one of those antiviral drugs I mentioned. And in terms of remdesivir as a treatment for COVID-19, there are a number of reports which has come up, and it reduces the median recovery time from 15 days to 11 days, cuts it short by 5 days. And mortality, very little reduction. Statistically, it was not significant, but there's reduction. And also serious adverse events are slightly reduced. However, it's a parenteral drug and inadequate supply due to complex manufacturing process. So the researchers then thought, if we are not enough supply, then we will give 5 days instead of 10 days in severe COVID-19 patients. And this is the results. As you could see, the horizontal, it says the first block is invasive mechanical ventilation. Second block is high flow oxygen therapy. And third is low flow, and fourth is ambient air. So whether you give 5 days or 10 days, the people who get maximal benefit in terms of death and so on is actually those who are getting high flow oxygen or invasive mechanical ventilation. And if you look at it very carefully, the 5-day group had a higher mortality, as you could see, compared to the 10 days. So those who are going to really benefit by remdesivir is actually those who are invasive mechanical ventilation. Now, what about dexamethasone? This is the study from here, published by the group in Oxford. 2,100 patients had 6 milligram dexamethasone orally or IV daily for 10 days versus 4,300 usual care patients, and 482 in DEXA group, and in percentage, 22.9 and 25.7 died within 28 days of randomization. But if you subgroup them to receiving ventilation, then the death in the normal group is 29.3, and the DEXA group is 41.4 in usual care, 29.3 in dexamethasone group. So in other words, there's a significant reduction in deaths of those who are receiving ventilation. But if they're receiving oxygen but non-invasive ventilation, the difference is not so much. So those who are likely to benefit are those who are going to get dexamethasone because of invasive ventilation. And the no respiratory support, again, with usual care, there is no difference. So conclusion is lower mortality with dexamethasone in those who are ventilated and on oxygen. And it is a cheap drug. It is readily available in the WHO essential drug list, and now it has become a standard of therapy all over the world. And there are guidelines which are drawn for corticosteroids for COVID-19, and that has become standard practice. What about chloroquine and COVID infection? It has been shown that if you take high or low dose, it has no major impact on the disease. Now I will read the conclusion. The preliminary findings of the study suggest that higher chloroquine dosage should not be recommended for critically ill patients with COVID-19 because its potential safety hazards, especially when taken concurrently with azithromycin. These findings cannot be extrapolated to non-severe COVID-19. But nevertheless, it is not recommended as a standard therapy because of no shown benefit. Of course, people like Trump, past president of the US, said we can take hydroxychloroquine as a prophylaxis, and there have been studies done for that too. And as you could see, there's the column on the left side is hydroxychloroquine, nearly 414 patients, and placebo. And confirmed or probable COVID is same on both sides, and laboratory confirmed also almost similar. So otherwise, conclusion is actually hydroxychloroquine is not prophylactic. It is not useful, and it is not necessary to give hydroxychloroquine. It can be given to prevent the infection. Now, there are other publications which are concerning about the use of ACE2 inhibitors and receptor blockers for those with hypertension, whether it is safe because it tampers, the virus tampers with the ACE2 receptors. And it has been shown that you can continue to use the ACE2 receptor blockers or ACE2 inhibitors or receptor blockers because it doesn't affect the disease. So until further data is available, we think the RAS inhibitor should be continued in patients in otherwise stable condition. What about plasma therapy? Well, there have been a number of studies that seems to show some improvement. This is plasma taken from convalescent patients, and they looked at the outcome and essentially looking at patients with severe and life-threatening COVID. And the conclusion was among patients with severe or life-threatening COVID, convalescent plasma therapy added to a standard treatment compared with standard treatment alone did not result in a statistically significant improvement in time to clinical improvement within 28 days. However, they concluded that the studies were underpowered, and now there are companies who are trying to isolate antibodies and produce them commercially as monoclonal and different types of antibodies. So you have a pool of antibodies given to a patient with COVID, and the trials are going on at the moment. So monoclonal antibodies for prevention and treatment is becoming more and more. Neutralizing antibodies have an important role in protection or recovery from many viral infections, and several monoclonal antibody products will enter clinical trials over the next few months and be assessed for the ability to live it. Because when the virus goes, the body produces not one single antibody, it produces a number of antibodies. So it identifies the different antibodies and try to produce the different types of antibodies, the best antibodies to tackle the virus, and produces commercially, artificially, and pull it together. So it might become a therapeutic tool and in control of the COVID pandemic. So this shows promise it has. But the most promising attack seems to be looking at seroprevalence. How many people have antibody? Seroprevalence is how many people in the population have been infected based on presence of antibodies on population screening. And herd immunity is also known as population immunity. It's a concept used for vaccination. So you have to vaccinate a number of people to prevent others getting infected. So you can protect from the virus. What is the threshold of vaccination is reached? So just to give you an example, the first figure, this is from Journal of American Medical Association. So this is 100 people with one person who is infected. Now, if that person passes on to 2, the first day it's 2, then these 2 people will pass it to another 2, there will be 4 people infected. If the person passes into 3, then it'll become 3, and more people are going to get infected. So this R is equal to 3. So the numbers that need vaccinated for herd immunity is calculated as the 1 minus 1 upon reproduction rate. So if they're passing on to 2 people, then 50% need to be vaccinated. If they're going to pass it to 3 people, then 67%. And if they're going to pass it to 6 people, then 83%, and so forth. So there is a rough calculation on how many people are going to need to be vaccinated in any population. Unfortunately, the natural herd immunity seroprevalence is very low. This is some study from the UK published in the Lancet. And in London, the seroprevalence is about 15% from blood donors. And those who came to donate their blood so that the antibodies can be identified and then they can be used. And different cities or different regions of England shows different. So there was this interesting article published in July. There must be a herd for herd immunity. So in other words, when they test, the total number of tests are in the light blue, and the dark blue little is the positive test. Like you can see the percentage positive profile varies quite a lot if you take it whichever way you want to, but it is certainly less than 10%. Maximum it goes to 15%, whereas we need at least 60, 70, 85% to be seroprevalence positive. So the only way you can get it, herd immunity, is a combination of natural infection plus immunization. Till then, we need to continue the public health measures like social distancing, masks, frequent hand washing, and so forth. So there are a number of candidate vaccines recorded in the WHO, Oxford University's adenovirus vaccine, AstraZeneca, Moderna's mRNA vaccine, entirely new vaccine, new technology, Pfizer mRNA vaccine, CanSino adenovirus vaccine, Sputnik vaccine, Sinovac, and so on. So I'll give you a gist of all these viruses. So what is happening is actually the next generation vaccine or the new generation vaccine are based on coding the genetic material. So the genetic material can be incorporated into the DNA, which is really the Oxford vaccine, and or into a lipid capsule in the RNA, which is the Moderna vaccine, and so forth. Now, the difference is actually the DNA virus vaccine has to go into the nucleus of the infecting cell, whereas the RNA can go into the cytoplasm and bring about the same effect. And there are other conventional one, which is like virus-like particle, and you can attach the protein so that antigen can be produced. You can have a live attenuated virus, like rubella and so on, or whole inactivated. The advantage of whole inactivated is that antibodies can be produced not only against the pegs, but also against other protein material in the virus. And so this is the DNA virus, and this is the mRNA vaccine, which is in the lipid capsule. That is the reason why the Moderna vaccine and Pfizer vaccine has to be stored at -80 because it's in a lipid capsule, whereas the DNA, the Oxford vaccine, can be kept at 2 to 8 degrees because it is the adenovirus. So that is a bigger picture of coronavirus and the spikes, and the spike protein is a small segment. And as you know, the coronavirus has different types of coronavirus, and the COVID virus has about 30,000 bases compared to the standard coronavirus, which is about 10,000. That's one advantage because the mutation numbers will be low and there is so many bases. So Oxford vaccine is based on the virus genetic instructions for building the spike protein, but unlike Pfizer, BioNTech, or Moderna vaccine, which store the instruction in a single-stranded RNA, Oxford uses double-stranded DNA. So that is actually the Moderna vaccine or Pfizer BioNTech vaccine, and this is actually the Oxford vaccine. Here it goes into the cytoplasm and starts releasing the RNA, and they produce antibodies. Here the DNA has to go into the nucleus, and then it sends the message, whereas on the other side is the RNA, which affects at the cytoplasm level. But then the storage is different, whether it's the DNA or the RNA. Now, about the RNA vaccine, these are the published literature. Pfizer BioNTech, you can give it after 16 years, Moderna after 18 years. The question arises about interchangeability with the COVID-19 vaccine products. And generally they say not to, although the end product is the spike protein and antigen, which is produced for the body to produce antibodies. They are not sure how it will each react. Co-administration with other vaccine, like influenza vaccine, is generally not recommended. Booster doses, they say you must, because booster doses manages not only the plasma cell, B cell to produce the antibodies, but also the T cells, the memory cells, which can last for years, even 10 years of a life. So that's why the booster is important. And this is where the question is arising nowadays on the TV, whether it has to be given within the fixed time. And vaccination of persons with SARS-CoV infection or exposure, well, not at the time of infectivity, but after they are recovered, then they can get the vaccine because it will boost the T cell immunity anyhow. And underlying medical condition, we have to judge it case by case, and also there is less experience with children and adolescents and pregnant and lactating people, but if they need it in a highly contagious environment, then we should go ahead and give it. Now, adenovirus is the Oxford one, so I'll give it a little bit more. It exists in the wild. In humans, typically cause mild infection, and it can be genetically engineered to express viral antigens found in SARS-CoV and spike protein that coronavirus uses to infect. This engineered adenovirus triggers an immune response in the human body, protecting against COVID. So this is new technology, and this has been used successfully in Rift Valley fever, Middle Eastern SARS virus, vaccines for HIV, influenza, Ebola, and malaria, and so on. So it's a tested platform. And here they tested chimpanzee adenovirus, which prevented rhesus macaque monkeys from getting pneumonia when purposely infected with SARS virus. But only one surprising finding was when they did the control animals and the vaccinated animals, both had equal amounts of virus samples in the nose swabs. So in other words, they were not getting infected and getting the disease, but whether they will transmit the disease is one of the questions which has to be answered, because if they carry it in the nose, they might carry it. So now the trials are over, but continuous surveillance is quite important. So this is the adenovirus vaccine. As you could see, the virus itself, it's a non-replicating adenovirus. So once you put in, it is not going to multiply itself. It will just go in and release the RNA, which is going to produce the spike protein, and then the spike proteins get out of the cell, and the body reacts against the spike proteins to form the antibodies. So there's nothing to worry about the virus. There are a number of studies from the mRNA vaccine, and it has come into the market. As I mentioned, the mRNA vaccine, because it's in a lipid capsule and it's an RNA strand, it needs refrigeration at -80 degrees centigrade. But China, USA, UK, all have made these publications in reputed journals, so there is nothing to worry because it has been checked by data safety monitoring committees, and it has been passed. So the unnecessary alarm whether they were tested correctly is not true. They have gone through phase 1, 2, and 3, but they did all the trials in parallel. But that's not enough. I think we have to continue do surveillance on post-approval vaccine surveillance. What is happening to the people, and what happens to post-license evaluation of COVID-19. So the purpose or urgency for giving the vaccine and putting a concertina-like effect of phase 1, 2, and 3 is to reduce hospital admissions, ICU admission, and open up social life and livelihood and economy, and to reduce mental health problems because people are locked up. So it is one caution with the vaccine, although it can offer direct protection, whether they will be transmitting the disease if they get it again is not clearly known. So that's why we have to come into public health measures. The other area of contention is the booster vaccine, where the UK government has put it to 12 weeks. The reason for booster is actually initially the plasma B cells produce the antibodies, but as time goes on, then there are the T cells, which are specifically tailored to identify a particular pathogen and kill it. And it can last for a lifetime, but crucially, we have to have a boost antigen challenge in order for the T cells to multiply and get established. So once you had your boost, you will have a high frequency of memory T cells to some extent for the size of the pool of memory cells you have, and they all be making higher quality antibodies as well. So the booster helps produce high quality. So I think there are two important reasons. A secondary boost of antibodies, plus also increasing the T cell population. Now, additional problem has cropped up as genetic variants. It is about 10% of those found to be positive are tested for genetic constitution in the UK, not so much in the USA. They are not tested recently. But the questions I have answered, transmission and infectivity seems to be increased. There is no question about that. So because the virus has mutated to increase the infection. Most infected cases, we can reduce it by strict public health measures. That is why the government is emphasizing that with the variant, we have to close borders and also prevent. Now, the severity of illness doesn't seem to be increased, but the hospital admission is increasing, not because of the severity of illness, but more people are getting infected. Effectiveness of the vaccine with the mutant variant is likely to be okay because the vaccine not only produces or PEG proteins one area only, but it produces a number of antibodies. So it might tackle the variant antigen which is coming up because of multiple antibodies. So tests from antibody produced versus virus, now they are doing tests to see whether the vaccine they are giving will be effective against the mutant virus. So they take the mutant virus component and from the recovered patient, they take the plasma and see whether it will mop up and seems to be working. So there need further studies has to be done. If it doesn't work, then you have to have future modifications of the vaccine. And with the mRNA platform now and the RNA techniques now, it's easy to substitute an additional few bases to produce the vaccine necessary. One other problem is actually the acceptability of vaccine. And this is a paper which I published some time ago saying that occupational risk for prevention in Asian, Black, and ethnic minority group seems to be having a high incidence. And these are the group who are not very keen to get vaccination because of misconception. There is a misconception going in the Facebook saying Gates Foundation gave a lot of money for vaccine production. They must have introduced microparticles in the vaccine, which goes into everybody, and they keep a database. All sorts of funny stories going around. So we have to really encourage people from minor ethnic community and those who get illness and die over 80 years, and those who have illness, they have to take the vaccine. So let us compare what is happening from Spanish flu. The antigen antibody testing has been successful. Antivirals are working, steroids are working. Track and trace facility is not excellent, but still some useful. Better ICU facilities and promising vaccines are coming that will lead to herd immunity. On the 1st of December, the global statistics showed 63,000 people infected. This is the number of cases compared to Spanish flu. 100 years ago, where 500 million people got infected. Number of deaths are 1.5 million compared to Spanish flu, 20 million. I think with the vaccine and herd immunity, this number of immunity, the number of cases might go up to 100 million, and the fatalities might be 2 million. So, but the success would depend on universal vaccination, not only on vaccinating those people in the UK or Germany, but all over the world, because people will bring the infection back in. So the Gavi Alliance, which is the Global Alliance on Vaccine and Immunization, has to work with WHO, European Union, and so on, and try to give vaccine to the poorer countries as well. Now, this is the latest figures, and as you could see, the number of deaths and so forth, it has gone up quite a lot. As you could see, 367,000, and the number of deaths, can't see the screen fully, but I can read it out now. Okay, as of 24th January, confirmed cases was 97 million, new cases 367, deaths 2 million. So whether we can hold the deaths to under 3 million by the time we bring global herd immunity is the question, and also the number of confirmed cases to less than 200 or 100 million or 150 million. Now, there's also a question about anaphylaxis, and the CDC has released the figures that 11 out of million get anaphylactic reaction based on 1.8 million doses given. And it seems to occur within 15 to 30 minutes, and most had a history of allergy. But even those with allergy, you don't have to worry too much if you have all the drugs available to treat anaphylaxis, because thousands of allergic people had vaccination, and prompt treatment has been given for those who had the anaphylactic reaction, and everything has been quite well. ephedrine. So vaccines are going to be the key, but public health measures have to be continued. And as you could see on this cartoon here, we are pushing hard on vaccine against the COVID, but these people are wearing, the boys are wearing a mask as well, because both has to continue, because the mutation is taking place all the time. So we can't let it just go free. We have to push hard. So in concluding, the future of humanity with COVID, we would do better compared to Spanish flu, because China gave the details of the genomic structure of the virus very quickly, within a week. This gave a head start on producing the vaccines. Secondly, there was already an existing mRNA vaccine platform where they can, with modern method, they can substitute RNA particles and produce vaccines. And thirdly, several governments and philanthropic people gave money and so forth to help production of vaccine, but it has to be equitable distribution, so that we should prevent people getting infected and immunity, because even if they get infected, there are long-term mortality and morbidity. Morbidity is on the lungs, kidneys, and brain. So we want to save them, not only life saved, but also the long-term action has to be saved. So I think in conclusion, I could say we will reduce the cases from 150 million to compared to 500 million infected. We might stop with 150 million, and we might lose 3 million totally before we come to an end, compared to 20 to 50 million. So we would have vaccines would save about 48 million. So there is light at the end of the tunnel. I think tomorrow will be better than today, but we had to work together, looking at poorer countries as well, and we can meet again. So that picture gives you some idea that light is at the end of the tunnel, and we have to need to keep going. So thank you for your patient listening.